Welcome everyone to today's asthma webinar. My name is Dr. Morgan. I am a GP in Camden and I chair the NCL Training Hub, which is really proud to lay on this long-term condition series of webinars. We've done the diabetes ones and that's recorded. If you didn't manage to make it, you should be able to find the links on the emails or let us know. And today is asthma, and then we've got COPD and hypertension already scheduled and heart failure coming at some stage too. I am delighted that Jacqui and Darush are going to lead for us. They're going to take questions part way through and at the end, so please do use the chat and also to put your emails if you want the slides and the recording emailed to you. I'll hand over to Jacqui and Darush to introduce yourselves.
Hi everybody, and thank you for coming. This, as Sarah's mentioned, is the asthma webinar to support the NCL long-term conditions and also working in partnership with UCLP. I'm Jacqui Hodgson, work in Barnet. I'm the training hub lead at Barnet, and also I've worked with asthma patients for the last 25 years in primary care. Darush, just a little bit of introduction from Darush.
Yeah, hi everybody. Nice to be here. So I'm Darush. I'm a respiratory pharmacist based over in Barnet Borough, North Central London, CCG. A lot of you hopefully will be familiar with Right Breathe, which is an app and website. So I'm a respiratory pharmacist with that group as well, and also part of the Primary Care Respiratory Society's executive committee and part of the Asthma Right Care team.
Next slide. So as a way of introduction, what we thought we'd do is just have a look about what asthma really is, a little bit of a brief diagnosis and objective testing during COVID times at the moment, management and monitoring, essentials, treatment choices, and some a really good acronym that we are sort of hanging this talk on really is something called SIMPLES. That was introduced by Anna Murphy in 2014, and that actually is a good way for you to be looking at making sure you complete all these things when talking to your patients, and also for your patients to be looking at that as well as managing their own condition. And that's S for smoking, I for inhaler technique and investigation, for monitoring, P for pharmacology, lifestyle for L, E for education, and S for support. So let's kick off with the next slide, please. So I use this slide quite a lot to explain to patients what asthma is all about, because I think if you have the buy-in with the patients of what's happening regarding bronchoconstriction as well as inflammation right from the start, then you'll get better buy-in with their management and their adherence to inhalers. As you're probably aware, we've got the smooth muscle on the outside of the bronchial tube. This gets tightened, making the airway thinner and narrower and more difficult to breathe, at the same time as you've got that inflammation and swelling and mucus production. Next slide, please. This is a little bit more in detail, and it does illustrate what's happening below the surface in more detail. And we're having more of an understanding now of eosinophilic asthma, which is high levels of eosinophils. That's the white blood cells, part of the immune system, which fights infection. And in the bloodstream, this causes it to become inflamed. You get the mast cells involved, and goblet cells, which produce the sputum and the mucus, making the airway narrower. For those of you that have more interest and a little bit more detail, I just want to bear in mind this is a very basic talk, so I don't want to complicate things too much, but do have a look at some of the asthma phenotypes that we are getting to know and hear about. Things like you might have heard of allergic asthma or eosinophilic or non-eosinophilic asthma. And they're generally looking at going into phenotypes 1 and 2 now, whether there's inflammation in the airway or there isn't inflammation in the airway. And don't forget, we have our respiratory tract is part of the nasal part going down all the way to the lungs. So don't forget the upper airway when we're looking at asthma and the coexistence of allergic rhinitis asthma. So further reading will be needed following on from this talk if you wanted to look at those sorts of things in more detail. Okay, next slide, please. So this slide is taken from the Asthma UK website and looking at the scale of the problem, and although those figures are there in 2015, probably left those there specifically because actually if you looked at 2017 figures, we still got 1,484 people dying of asthma each year. So actually we haven't improved things over the last 2 years, which is a bit sad really, and hopefully we'll sort of allude to some of the possibilities of why that is. And hopefully we can move forward in some of the new guidelines that are in the pipeline moving forward. Thank you. Next slide, please. So first of all, the National Review of Asthma Deaths. This is still a really important piece of work, and it is almost 2014. It's quite 6 years ago now, but it is very relevant. And it's looking at a mixture of reasons why people were ending up in A&E and dying of asthma. Firstly, it brought out a lot of hidden asthma and uncoded COPD really, and people were coded incorrectly as COPD. They were encoded incorrectly as asthma, and when actually they were probably COPD patients that are attended in A&E. Also, there were some start figures of patients underestimating their symptoms, not knowing what to do in an emergency, not having a personal asthma action plan, and not being seen in the last 12 years of an asthma review. And these are all the people that unfortunately died in the UK that year, when they were doing the study, 195 people. Next slide, please. So this highlights the statistics really, that actually those people that are dying are not those severe asthmatics in stage 4 and 5, but those asthma patients just steps 1 and 2, only taking an occasional salbutamol, although they ought to be on a mild inhaled steroid, and those patients that are generally managing well, and then all of a sudden something happens. So it's those people that are in those lower categories that were dying, and possibly still are. So next slide, please. So this is a slide that probably a lot of you are familiar with. We know that asthma is triggered by various things, and each person is an individual, and one person that might be triggered by exercise, somebody else might not necessarily be triggered by exercise. They might be triggered by pollen or pets. And you can see around the slide there, there's a lot of factors that do trigger people's asthma. Why it's triggered with other people and not those, it's a lot more research is going into that. And again, something that's not going to be going into on this slide. I do want to draw your attention to house dust mite, one of the biggest triggers, and actually informing patients when you are doing your reviews about the guidance of washing the bed linen at 60 degrees or more to kill the house dust mite. And also soft toys in the freezer is another good one to get rid of the house dust mite. Asthma UK website, and we can allude to some of those. Maybe Darush can put the website in the chat bar there. Is a really great resource for patients to have a look at how they can avoid some of these triggers. Because if they weren't triggered, then hopefully their symptoms will be much more in control. Next slide, please. So smoking. So obviously smoking is one of the biggest triggers, and we just wanted to go in a little bit more detail around the smoking cessation. And this is a poster that was introduced for Quit for COVID. And actually I found when I've been speaking to some of my patients, some patients have gone back to smoking during COVID because of stress. Other patients have actually used it as a way of thinking, well, actually, I do really need to make a change. every appointment counts, every conversation counts, and so don't forget to ask every time that you speak to a patient, even if they've got ex-smoker in their notes, to actually ask them again, are they still an ex-smoker? Next slide, please. So you'll all be aware of the 3 A's, the ask, first of all, for smoking cessation, and this is the very brief advice. And getting the wording right is really important, I think, in this. And actually, there's some questions there. So, are you still smoking? How's the stopping smoking going? Look at the left-hand side of this slide, much more than the right-hand side, because you're going to get more buy-in from the patients about the way you ask. It's not just about asking how many they smoke. That really is quite irrelevant. It's about how you can support them moving forward to stop. Next slide, please. So ask, next one is advise. So how do we best stop? What is it? Again, looking at the left-hand side, did you know the most effective way to stop smoking is a combination of support and medicine? So giving them that information, and both are available, and offering them the opportunity to make another appointment. It may not involve actually doing anything physically at that point, but actually pointing them in the right direction, and a little bit of something comes into the patient's mind just to sort of jog them. Lots of behavioural support with the smoking cessation advice service, and there's a lot of resources on the national smoking cessation training for you if you would like to do more training on that. AA, we've got ask and advise. We're next on to the 3rd A. Next slide, please. That is act. So this is the signposting, best available to support with the treatment. So, okay, it's fine at the moment if you're still smoking. Don't worry. If you change your mind, we're always here. These are the sort of things that patients may be much more receptive to than actually telling them, being more negative. That's what I'm trying to put there. So directing the patients to the available support and treatment for them to quit, and actually keeping a note in your practice notes, or the way you do your notes at work, is to actually think about how you're going to remind them next time. Are you going to have a text message that you might just want to jog their memory? We're still here. Is there anything else that you want for us to support you going through that? The primary care respiratory there has got some great resources around instigating a quit attempt. So I do encourage everybody to look at that Primary Care Respiratory Society resource. They are our mainstay really for any respiratory work in primary care. Next slide. So this is my very sort of simple way of thinking about how we're going to do asthma diagnosis during COVID. As we are aware, it is about detailed history with asthma and sometimes building up a picture over time. As you can see, the symptoms, interestingly, asthma doesn't really have a definition. It's got a list of presenting symptoms that may point towards asthma. So these lists on the left-hand side there, cough, tight chestness, dyspnea, wheeze, or maybe nasal symptoms, variability, allergy, triggers. Those are all the things that we need to be finding out from the patients to build up a picture to see, is this looking at being asthma diagnosis or not. Obviously, there are particular objective tests, and spirometry, according to NICE, is the standard for doing asthma diagnosis. However, at the moment, we are all aware that that's a aerosol generated procedure, and we aren't able to do that. Equally with FeNO, which is fractional expiratory nitric oxide testing, which measures the amount of inflammation in the airway. This is an excellent way of finding out whether there's any inflammation and possible asthma diagnosis, and it can be used to help. Again, that's a very limited resource in primary care at the moment. Prior to lockdown, we were beginning to sort of hopefully in Barnet have that running, and we sort of came across a few hurdles, which is a shame. But it is still there, and maybe a less of an aerosol generating procedure, and maybe something that might be thought about when we start opening up post-COVID as an option. So we go back to our great peak flow diaries, and the peak flow diaries were around 20 years ago, 25, 30 years ago when I first started doing asthma, and as the only sort of thing that we used to do. And actually, I think they're very, very powerful. So I think if we can actually encourage everybody to be prescribing a peak flow diary for people at home and doing some diary monitoring, that's the way forward for our objective testing this time. And I think you can probably tick your box on the QOF objective testing to be able to do that. So looking on the right here, this is following from the BTS guidelines. We're looking at building up this picture, building up this story, building up how many times I've had this sort of episode of cough, whether it's a nighttime cough, is it triggered by anything particular? Is it triggered by exercise? Is it spring? Various things that we have in our toolbox to be able to sort of point to it is high probability. Then we would code in the notes suspected asthma and do a trial of treatment using a decent dosage of an inhaled corticosteroid for 6 to 8 weeks. And that's what the BTS 2019 guidelines is actually saying to us. With a peak flow variability that you can get them to monitor at home, 20% variability is a diagnostic tool. You may want to, if they have a short-acting bronchodilator at home, a salbutamol they've already had, ask them to do a peak flow prior to doing bronchodilation, and then another 15-20 minutes to see if they've got any reversibility and increase in their peak flow. Next, in the NIA BTS guidelines, we've got the moderate probability, and that's when you're just not quite sure. It might not be quite as variable as you want it to be on the peak flow, so you might want to suggest some other tests. The slide there is just moved across, so it actually should say bloods for eosinophilia and IgE. That will measure that whether or not there's any inflammation. That gives us a pointer towards whether it's asthma. You might think that they could do with examination for wheeze. Now, you could do that as a video call and actually get them to be in the camera, and you may well audibly hear a wheeze, which would also point towards an asthma type of diagnosis. If they were particularly unwell, or they actually are in the practice and it's a safe environment using the correct PPE, you might actually choose to bring them in and get them to be examined to check for wheeze. Again, looking at all that in conjunction with the peak flow diary for variability. If you're not sure, then again, seeking expert support by anybody in the practice who may be a bit more experienced at asthma, or using our expert patient consult connect ability. I'll show you one of the apps later on. That's been very helpful during COVID. Low probability, that sometimes are harder to unpick, and some of the symptoms of other respiratory conditions of COPD and bronchiectasis, cough and those sorts of things, plus unpicking all of the problems that we are experiencing at the moment with COVID sorts of cough, is you may well need to actually refer to the consultants and the specialists to be able to help you move forward with your diagnosis. But if we were just going to stick with the very simple asthma diagnosis, hopefully we'll get that from peak flow diary monitoring and the probability and trial of treatment. Okay, next slide, please. So this is just a lovely graphic image, again, showing patients. This is quite a useful thing in teaching patients when they're doing their peak flow diary. I've been sending text messages with the link to the peak flow diaries that they can then send photographs back of their own peak flow. And classically, at the beginning of that graph, it's an untreated asthma. You can see that their airway is variable. It's possibly down in the morning and up in the evening, not necessarily that way round, but that's often a picture. And it's lower than what their expected peak flow would be for their height and age. That's calculated according to their age and height on the EMIS computer. So you would then send them away, start their inhaled corticosteroids treatment, and actually get them to monitoring. And you can see how it goes. It goes up and it gets to a lovely, not much variability at a higher level, probably where they need to be. Next slide, please. Just about the peak flow, we often go with patients' best peak flow because it might be they're expected for their height and age, but they may never reach it. So we need to work on their expected peak flow, and that's a useful thing to be recording in the notes. Another way now of objective testing and actually checking is their asthma control test. This is available in the electronic format, and if you go onto any of the Ardens templates, there is a link to that, and it goes electronically through. It fortunately doesn't self-populate the asthma control test, but you do need to actually put the number in. And it's asking those 5 questions. During the last 4 weeks, how much of the time has the asthma stopped you from doing what you've wanted to get done? And they score on the scale of 1 to 5. And in the last 4 weeks, how often have you been short of breath? Next one, 4 weeks, how often has it woken you up at night or early in the morning than normal? How often have you used the bronchodilator in the last 4 weeks? And how would they rate their asthma control? And he gets a score out of 25. This is the adult one. There is a pediatric one, just to let you know, of where there's some pictures that the children under the age of 11 can fill their own questions in, and then their parents or carers can fill the second part in, and that's out of 27. And we've been sort of thinking about using this as a very good guide during COVID, to be thinking about anybody that's returning their asthma control questionnaires back to us over 20. We can be quite sure that they're quite safe, and a lot of the asthma review can probably be done by a series of messages via texting with attachments of action plans and guidance what to do in an emergency, and if their asthma is reducing and any symptoms they're experiencing. So doing it through the text service is great. Then if their asthma control test is scoring sort of around about 15 to 20, that's where we're looking at a little bit more detail of what to do. And actually, you may want to bring them in, or you may want to do a video call, and you may need to speak to a prescriber to actually think about, do they need to be adjusting their medications, as well as checking inhaler technique, and going through all the other checks that we need to do. We will be alluding to those in a minute, so don't worry, I'll continue a little bit further later on about the asthma management plans in more detail. And then under 15, I think that's much more serious, and actually patients need to be reviewed by somebody who is an asthma specialist, and actually ensuring that they are safe. There's no red flags. They're not going to be ending up in A&E unnecessarily. So we'll need to definitely touch base with them within that 24 hours if they're scoring under 15. And the last question there is an interesting question, because patients do actually perceive their asthma differently than what we might perceive. So actually for them, using a salbutamol inhaler on a daily basis might be good control. But I think it's for us to actually hopefully educate them that actually that's probably not where we should be, and we want them to be using as little salbutamol as possible. Darush will talk about medications in more detail later. Next slide, please. Yeah, a little bit now about the guidelines, BTS 2019, and that's where I was alluding earlier about looking at the probability and doing a trial of treatment. and then the NICE 2020 guidelines, which is more gearing towards spirometry and pheno. And I do think that the guidelines have muddied the water a bit because they do work very differently. But do watch this space. Next year we are hoping for a consensus report between the two guidelines to hopefully get one guideline that we can work with. But in primary care, we're definitely using BTS where I work, and I think that works much better during our remote working. I also want to allude to the GINA, which is the Global Initiative of Asthma Reports. That is saying around about that they are actually not a guideline, but they're a globally recognised arena, and they've got good guidance about the management of asthma during COVID. And I'll have a look at that later on if you wish to do so. And they are thinking, although this isn't published work yet, that maybe inhaled corticosteroid in the form of a combination inhaler with formoterol may be the first step when we move forward, helping with symptom control very early on. Okay, next slide, please. So I don't want you to sort of spend too long on this. This is the BTS guidelines, and actually it's what I've alluded to before on the left-hand side, thinking about probability of asthma, coding as asthma, initiating the treatment, and then checking if they've got a good response or not. Next slide, please. This is the more complex looking NICE guideline slide where pheno pops in, and again that's been difficult in primary care. So they are there for people to have a little look at, but please think about the guidelines that are going to be coming up soon. Well, I don't know whether COVID's going to delay everything, but it may be they'll amalgamate these soon. So hopefully we'll get some a bit more of a clearer work going forward. Next slide again. So this, although it's a busy slide, I think it's an important slide for those of you that probably are not doing asthma reviews very much at the moment, but for you to help you sort of as an aid memoir to guide you. It's from Nature article this year, and looking on the left, thinking about when you do your asthma reviews, what to cover. Looking at history, assessing the symptoms, and looking at the short-acting bronchodilator use in the past weeks. Assess their control using the validated tool, and I've actually spoken about that with the asthma control test, and actually using assessing their inhaler technique, and Darush will go into that a little bit later. You may want to be doing a video call for them to demonstrate the inhaler technique. That's all we have, and actually recording on our QOF guidance demonstration of inhaler technique will be sufficient. Looking at their risk of exacerbations, asking if they've had any symptoms that have increased recently, and beyond the normal for their day-to-day pattern is an important thing to be thinking about. Home peak flow measurements, home peak flow meter readings will come back in their own. I've again alluded to that. And comparing with normal values, height and weight and age. Checking optimal use of maintenance medication. Are they using it? Asking open questions here is really important, because if you ask somebody at the very beginning of the consultation, what inhalers are you using? It's such a bad question, because they'll say, oh, the blue and the brown, and the blue and the brown is not going to help you at all. So asking more sort of probing question, how often do you take your medication? How often do you forget it? And then they'll be honest, and then we'll say, actually, I've only just restarted it last week. I was not using it before. Or, yeah, I forget it a lot. That's fine. It's okay to acknowledge that, but it actually gives you much more understanding of what's happening in the real world. Then having a look at evaluating signs to see how difficult to treat their asthma is, or how severe it is, and whether or not the symptoms are persisting despite the use of the medications correctly and within good inhaler technique. So then, do we actually need to confirm the diagnosis, or do we need to think about something else if it hasn't quite gone to the same pattern as we wanted it to? And then making up a follow appointment. Consider this as, again, a virtual one or a face-to-face, And then don't forget, we're doing virtual group consultations, and these webinars are all about supporting that work we're doing throughout North Central London with virtual group consultations for long-term conditions. Next slide. Again, this is a little bit more reiterating about what a good asthma review is, and this is the Primary Care Respiratory Society building blocks, which is really useful. That's actually talking about assessing control, severity, risk of exacerbations, reviewing diagnosis, examination, inhaler technique, smoking, all of those simple things that we've alluded to at the beginning. And collaborating with the patient, actually working together with the patient to actually look at their personalised action plan. A personalised one meaning, what is it for them personally that makes their asthma trigger? It might be one thing for one patient and not for another. Next slide, please. So these are the Asthma UK web page, adult asthma action plans. There are paediatric ones as well, and you can see they're really good. They're in the green, the amber, and the red zone. And going through that with the patients is really important. And writing in that, what is it about their asthma? This is a good guide, and it might say, Sarah, in the middle, you're saying, I wheeze more often, or I cough, or I use my inhaler more often. But for some particular person, it might be that I go to Granny's house and she's got a cat, and I always have an asthma problem when I get there. So that's what I mean by making it personalised and working together with the patient to actually get that personal bit in the plan. And I do say it is quite time consuming. There are links on the Ardens templates and EMIS to click to organise these and attach to the patient's notes and send via AccuRx. Versions there are, because there are some ones that are a bit older than others. And also we inhalers in a MARCH regime, which is maintenance and reliever therapy, and some of the asthma plans are not as geared out for that. Next slide, please. Then this is the again the other side of the asthma plan, and at the bottom there is the place where you can put MARCH guidance, and actually it is a little bit small there, sorry, but you'll be. And usually if you've asked them to take an action, either it's upping their steroid dose, or increasing their combination inhaler to 8 times a day, what you'll need to do is actually follow them up and say, well, actually, if there's no improvement within that 24 hours, please let me know, because things might not be as good as they could be. We need to move and escalate things over. And then in asthma attack, I mean, attacks patients, they think, well, it's an attack. It might not be an attack. We might call it an exacerbation, that they really are finding it really difficult to breathe. They can't talk in sentences. They may need to use 10 puffs of their salbutamol over 10 minutes, phoning an ambulance, ideally with a spacer if they've got one at home. So another thing good to make sure that they have a spacer, they know how to use it, and it's cleaned and regularly changed once a year. And also using, if they haven't got a short-acting bronchodilator, which I'm hoping not many people need to have these days if they're on combination therapy, using 6 puffs of their combination inhaler. Next slide, please. Yeah, sorry, this is a little bit more detail about the personalised asthma action plans, and about making specific things for each patient, about individual triggers, and recognising and avoiding those triggers, and trying to understand their asthma more. I think asthma is, it's always difficult because patients do feel well a lot of the time, and they forget that actually when they're not well, what to do. So this is the importance of those plans. Next slide. This is management of acute asthma in general practice, and this is moderate, acute, severe, and life-threatening. And I just want to allude to that, the assessment, looking at whether the patient's not been able to talk in sentences. Yep. So respiratory rate over 25, pulse rate over 110, and oxygen saturations under 92. this is worrying and we need to actually consider admission. So those are the key things that to make sure everybody is aware of those severe asthma sort of cut-off points. And if they have got a peak flow diary, then if it's dropping below 50% of their best, and that's the conversation about you need to be doing with their peak flow diary and self-management plans. One more slide, please. So just wanted to allude to all of these amazing technology that we have available to us and we are using, and I don't think we could do our work without them. AcuRx has been phenomenal, and actually a lot of my consultations are run like that. The next little icon I've used Consult Connect a lot. I phone up a consultant and I'm speaking to the consultant immediately about somebody that I'm actually not sure about, and I'm getting their expertise and their advice. That has been really helpful during COVID. Right Breathe has and always will be the most amazing app for telling you all about those 117 inhalers there are on the market and how they work, and links to videos that patients can use to help their technique. Asthma UK and the British Lung Foundation, they're obviously our mainstay charities, and without them we couldn't do our job because they provide so much support for patients. So please highlight that to every patient that we see. Arden's templates are really good, and I would encourage everybody to look and use those. We'll be alluding to some of the UCL partners work, which has been around about looking and risk stratifying low, medium, high risk patients, which I've alluded to a little bit in some of my management stuff there. Obviously, teams thinking about group consultations with patients. So it's all there for us. New ways of working, and I think asthma fits pretty well into this remote world. I don't know whether my colleagues on the call would say, but I think it can be managed quite well like this in the future. Okay, I think I'm going to pause now for 5 minutes if there's any questions. Has anything in the chat bar that's come up?
We've had quite a few questions that Darush has started to answer, but I think some of them might be worth flagging. So there was one about Catherine asking about the asthma action plan and how a consultant had said to do the green zone at 100%, amber zone 80%, and red zone 30% of best peak flow reading. But others seem to use higher percentages, and just wondering if there was some guidance about what percentage to use.
I think that over 80% and above is what we should be in the green. I think that's correct. I think some of the guidance has been, I think if you go to 30% and lower, my personal opinion is actually they're too sick by then. And so I think if you go from 60% and above for the middle zone and 50% and below for the more urgent, I think it is a bit of a safer way, because the guidelines may say 30%, but you don't want them to be in A&E. So if you can catch them earlier in primary care, I think I would go with the higher percentages. I don't know whether that's answered the question.
I think that's helpful. Someone was asking about spirometry and its availability, and we just confirmed that there's no availability at the moment across the whole of NCL, but that there is an NCL working party looking at that, and I know Donal, who's on the call, is helping to lead on that work. Then we've had some questions about the peak flow, how often to do peak flows, and Darush has suggested that when you're doing the testing, you might want to do it 2 to 3 times a day over a 2-week period. And then someone was asking how often would you do it during monitoring?
So peak flow diary monitoring is recording the best out of 3 readings in the morning and the evening to get the graph, and actually getting the technique right, ideally if they can do it standing up. And then once if you're using that as a diagnostic tool, I would do that for a good sort of 3 to 4 weeks to try and get them to see whether that graph increases from being variable and low to being nice and level and flat at a higher level. And another useful thing with the peak flow, as I said, is to maybe once or twice a day, if they are feeling they need to use a bronchodilator or their inhaler, to do it before that and then do it 15 to 20 minutes afterwards and actually see if it improves. And then moving forward, when they're well controlled, I think they don't, and I think they won't, I think we've got to be realistic here. People won't do this forever, and it's not, you don't need to do it forever, but I think it's maybe important for them to be reminded that when they're unwell, please come back to this because it will help you in your management.
Thanks. We've had a plug for the Right Breathe service, and then some questions about spaces, but I don't know, Darush, you have answered that in the chat, and I presume you might be talking a bit about that with your inhalers coming up, so maybe if you cover it then. So just one last question before we go into the next bit is, do people monitor their peak flow meter after use of SABA during their normal monitoring period?
I think it's a useful thing to do when they're assessing whether or not they're asthmatic or not, they have asthma or not. Darush, what are your thoughts with that? I probably would say not necessarily.
Yeah, I mean, you kind of answered it earlier on. I think it's useful to know your personal best peak flow reading, and then it's important to do it pre-SABA use and post-SABA use. You could do that. It's absolutely fine to do, but not necessary during the monitoring process. Yeah.
Okay, thanks. So, Darush, are you taking us into the next bit? Thanks. And will you pick up the bit about spaces just to as part of your bit as well?
Yes. Okay. So I'm conscious that I've got quite a few slides, and what I don't want to do is rush all the slides. So I'll signpost with some of the slides. I think it would probably be best rather than trying to rush some of the bits. But with regards to treatment guidelines, a lot of you will be aware of national guidelines, and as Jacqui has said, that hopefully we'll have one pharmacotherapy type of guideline that we can follow, because NICE has one, as well as BTS Sign, and there's also the global one, called GINA. So the one I've got up here is an adult one, just showing BTS Sign's latest one, which is going to be updated again. But you'll see right from the start of treatment, low doses of inhaled corticosteroid is the first step. I mean, the BTS don't call them steps anymore, but that's because asthma is an inflammatory condition. We need to treat it with an anti-inflammatory drug. And the blue inhaler, which is contains a short-acting beta-2 agonist, that is not anti-inflammatory. And the only time, according to NICE guidance, where you may consider a SABA alone is for short, for infrequent wheeze, and this means if a person's getting symptoms of asthma less than twice a week, really. But I think GINA is probably got the right idea, and they've got no circumstances really where you'd consider SABA alone. In children, that may look a little bit different, and obviously there's different guidelines there, especially with children under the age of 5. So I'm not going to go into that on this talk. But just remember, if you've got certainty, it's asthma, then that's where you would want to treat the person with an anti-inflammatory drug. And when we think of the drug, we need to think of, because these are inhaled medicines, we need to equally treat the device and the drug together equally as important, because unfortunately a lot of people can't get the drug to the lung, and if they can't get the drug to the lung, then of course they're going to have poor symptom drug. There's no point even prescribing the treatment. And as the steps move on, and this is where you really need to stand back and really look at the guidelines, just check, are they adherent to treatment, have they got the good inhaler technique, and have they got a self-management plan to go alongside this, because education is absolutely key in helping a person understand what they've got, because a lot of people think it's just a little bit of asthma and maybe not take asthma very seriously. But this is a variable episodic lung condition, and when somebody's feeling quite well, they may think, actually, maybe I don't have asthma anymore. And unfortunately, if a person is not treating it with anti-inflammatory drug, then potentially they can get inflammation going on and airway remodeling, and potentially it can cause problems for them. So regular preventer use would be ideal. And then as you're going further along, if a person is needing a step up in treatment, again, you step back and just check all the Simples model, which we'll talk about again, and check, and that's where you may introduce what we call a long-acting beta-2 agonist, or a LABA. A LABA should never be used by itself in asthma. No bronchodilator really should be used alone in asthma, because this has to be in combination with inhaled corticosteroid. And this can be either as a fixed dose where you take it morning and night, or some treatments are once daily and you take it regularly. Or there are, as Jacqui alluded to earlier, there's something called ICS with formoterol, which is a fast-acting, long-acting beta-2, and that could, if it's licensed, it could be part of a maintenance and reliever therapy treatment. So we have two options there. And then again, before you even consider going on to medium-strength inhaled corticosteroids, you might even consider things like leukotriene receptor antagonist and additional therapies. The good thing about the BTS sign guidance is it's really important that we don't put people on these very high strength drugs, which there are quite a lot of people being prescribed them in primary care, and we need to be watchful of that, because a lot of these patients should really be under a specialist care. Okay, next slide, please. So what I've tried to do in Barnet Borough, and share this across north central London, is really think of this medicines optimization pyramid right from the bottom. If we really need to make sure we get the diagnosis correct, because if we don't get the diagnosis correct, we're treating the wrong condition. And then be familiar with what we've got available nationally with regards to guidelines, and also what's going on locally within north central London. We'd have our North Central London MON website, where guidelines will be updated on there, so to look out for that. And I know the COPD ones were not so long ago recently updated, which are very good. And be aware of other, for example, societies like the Primary Care Respiratory Society, and what I try and do as well is share with colleagues how we can safely step patients down, because one thing we find in primary care is we may step patients up, and it should be temporarily, because the guidelines say that potentially after 3 months we can step the patient back down if they're well controlled and not exposed to triggers, etc. But that's something that's not done routinely, and they may stay on those higher strength treatments for a long period of time. So what we should do is try and step patients down appropriately when it's appropriate to do so, so they're exposed to not the highest. For example, if you're looking at inhaled corticosteroids, they're not without side effects, neither are bronchodilators. So if we can maintain a patient on the lowest possible strength to maintain the person's condition, then that's great as well. Plus, it's great on the reducing waste side of things, and less costly, obviously, the lower strengths. One of the things that if you go up the pyramid, inhaler technique, absolutely key. And every time we're looking at a metered dose inhaler, because research has shown if you're trying to use a metered dose inhaler by itself, around 9 out of 10 patients get it wrong. They may make one mistake. And the UK inhaler groups, 7 steps to good inhaler technique, which I'll show you shortly, is something that we should all, if we're involved in respiratory care, should really know this really well. So if you're using a metered dose inhaler and it's with a spacer, the number of errors will come down. We can improve that to around 50%, but still 50% will still get it wrong with a spacer. It's very important we show a patient and coach the patient, repeat it, and we're competent ourselves when it comes to coaching a patient, and get the patient to show us. During this time, we can do video consultations as well as if it's safe to do so. Sometimes it can be done face to face, but obviously it's not happening routinely these days. So I'll worry about inhaler technique coaching at this moment in time. And with telephone, it's very hard to assess, inhaler technique. So yes, Right Breathe and Asthma UK have got some great videos you can share with people, but unless we're watching the person and they're demonstrating it, it's going to be difficult. So I would say we've got the different inhalers. Remember, I was talking about asthma being an inflammatory condition. We are seeing a lot of patients being prescribed quite a lot of this short-acting beta-2 agonist, the blue inhaler, because a lot of patients will find that that one is the one that's giving them the relief. And unfortunately, if a person becomes over-reliant on this blue inhaler, they're putting themselves potentially at danger. And what I'll do is I'll show you this UCL Partners algorithm, which will help us identify which patients we should be targeting who are in particular danger. And remember, as well, is if we are identifying patients on high doses of inhaled corticosteroids, and this would normally be anything above 1,000 micrograms of beclomethasone equivalent, or it could be 500 micrograms fluticasone equivalent. Aware that these patients really need to have a steroid card, and that's something that we've been trying to get around. Prescribing by brand is absolutely crucial in respiratory. We now have 119 different inhalers, and we need to ensure consistency of device too, because unfortunately we're finding a lot of patients getting a dry powder inhaler, which is got a very different technique to say something like a metered dose inhaler and a spacer. And that's a problem, because it's hard to know one inhaler technique, let alone two different ones. So if we can consistently prescribe the same type of device and by brand, it will help. And very much against switching of inhalers to try and save money, because unless it's part of a shared decision-making process, it can backfire, and it will lead to poor adherence and also end up costing us a lot more. Those X's I was showing you just on this last bit is things like the in-check dial, not to be used at this sort of time. It's risk-benefit analysis is not there. Remember about secondhand smoke exposure. The National Review of Asthma Deaths found that was a real problem with children who died were living with smokers. So very brief advice around secondhand smoke is key. Try and, I guess, if you're going to give metered-dose inhalers, think of the ones with dose counters on them, because because a lot of people are finding when's it running out, and when we're thinking of the environmental impact. Okay, next slide, please. So these are the some really good reputable websites. As I said, the first thing I'll be thinking of, and I've spent quite a number of years practicing and learning from experts around these 7 steps to good inhaler technique. The UK Inhaler Group standards and competencies is something that we should all sort of follow. A bit like when I'm thinking of smoking cessation, I'd think of the National Centre for Smoking Cessation and Training. That would be my first port of call. The same applies for standardising our competencies around UK inhaler technique. And Asthma UK and UK Inhaler Group work together to produce these excellent videos. But what's good about Right Breathe, it also considers what the medicines that are inside those devices. So it will notify you if somebody's on a very high steroid strength, for example, or if somebody's or whether it's licensed for that particular age group. These are some of the questions we get, or whether the spacer is compatible with that device. These are questions we get quite a lot, and Right Breathe will help you with that. Okay, next slide, please. So questions you've been asking about spacers and inhaler technique. I thought this is a very good algorithm produced by a lot of members from the UK Inhaler Group. So Dr. Rosmani and there's Tony Capstick, who's a fellow pharmacist, and Jane Scullion and Azar Salim, who's part of Right Breathe. They came up with this very good algorithm. It kind of follows the NICE inhaler technique algorithm, but I find this one is simpler. It talks about the act, how we need to assess the person's ability to use that device, because if a person's not able to inhale quick and deep over 2 to 3 seconds from a dry powder, then, you know, we might be thinking of environmentally friendly inhalers, but actually if they don't have the ability to use that inhaler, there's no point prescribing that device. So if they've got a more slow and steady technique and they can inhale over 3 to 5 seconds, then that's obviously maybe suited to either a metered dose inhaler with spacer, or a soft mist inhaler, which there's only one at the moment called the Respimat, or a breath actuated inhaler, which was useful for people who find it hard to coordinate their metered dose inhaler. This session is not really going to be, I would normally spend a good hour at least on an inhaler technique coaching workshop. So I'm not going to go into that in detail today, but it's just to remind you all how important inhaler technique is. We've got to choose the right one that fits the right patient. And that's something where we need skilled clinicians to do that, as I said. And then we need to train and involve community pharmacies a lot more, who, if they've had the training, absolutely go for it. And during an asthma review, it's no point trying to rush inhaler technique. We should really devote good time for that. And the same with self-management plans, because I find sometimes they're rushed in clinical practice, and such an important part of the asthma review, and we should look at that. Okay, next slide, please. So these are the 7 steps to good inhaler technique. As I said, I'm not going to go into this in great detail, but just to say, for a dry powder inhaler, about 60% of people make at least one mistake. And don't assume because it's a dry powder inhaler that's the one we should always go for. As I said, if you haven't got the ability to inhale over 2 to 3 seconds, and dry powders also, some involve twisting, some involve shaking, some involve pulling, and mistakes can happen when preparing for that device. Happens quite regularly. And the other thing that happens quite a lot is people forget to breathe out and away from the device. A lot of people breathe into the device, and if it's dry powder, then the moisture will build up in the device and clog it up. So it's really important to breathe out fully away from the device so you can get that maximal inspiratory flow. And the other big problem with the dry powder inhaler is people weren't holding their breath for a good 5 to 10 seconds. So there's critical errors with all devices. So we shouldn't be thinking about just changing people from inhaler to inhaler without checking their ability first. Okay, next slide, please. So with suboptimal technique, you can get between 0 and 10% of the drug getting to your lung. If that is happening, you're going to end up having poor disease control. You're going to get more side effects because a lot of it will get into the systemic circulation. You may think, okay, this person's not controlled, so I'm going to step up on treatment, which wouldn't have been needed actually, which leads to more side effects. And it may lead to people using their blue inhaler a lot more as well. So if we can get the basics right, then I think that can really do a lot of good for all. Next slide, please. So the UCL partners came up with this very useful algorithm, and Jacqui earlier talked about the asthma control test, those very useful 5 questions, and we can do this remotely quite well and identify if a person is at risk. So if you look at group 1 patients, these are the patients who have got more severe asthma. Then you're going to group 2 criteria, and to be honest, when you're looking at these searches here, these are patients at risk. They are at risk. If you've got somebody using their blue inhaler, that's six SABAs, that's 6 blue inhalers, that's 200 puffs in each device, that's 1,200 puffs that patient may have been using. That is a cry for help. That is 1,600 to 1,200 breathless moments that patient has had, and we shouldn't take that as being well controlled at all, and this person is at risk of having an attack. We also need to identify people who have been on oral steroids, for example, look at their courses and antibiotics over the last 12 months. And we can also look at the ratio of the preventer inhaler and the SABA. So anyone who's had less than 4, for example, inhaled corticosteroids, they're non-adherent, and they'll be at risk as well. So this risk stratifying is very good. So next slide, please. And what we can do as well is this needs to be done as a real good multidisciplinary teamwork. I like this. We've got a pharmacist, a nurse, we've got lots of doctors on here, and this is how it really needs to work. All of us working together as a multidisciplinary team. Now, healthcare assistants are vital within our practices, and I think there's lots of things that they can do to support our patients. And I like the way that it's segmented into different categories. So people maybe, if we wanted to do a self-management plan, I would make sure that I'll be thinking within the practice who's got the skills to co-create in partnership with the patient a self-management plan, because that involves a lot of skills, and the patient needs to be, they're not going to use their self-management plan if it's just a leaflet that's been handed out. So we really do need to do that. And as Jacqui is alluding to earlier, it's very much asthma, and we need to think of the multimorbidities. So allergic rhinitis, the airway starts here, and if that's not well controlled here, it's obviously going to have a knock-on effect to the lower airways as well. So we really do need to think of the patient holistically. So next slide, please. This is a point I've been talking about quite a bit around the over-reliance of SABA. The National Review of Asthma Death talked about people who prescribed more than 12 inhalers. I mean, that is just a medical emergency. You've got to think of the blue as like an ambulance, a blue siren going off. This inhaler is not treatment. This is not the treatment. The treatment is anti-inflammatory treatment. The blue inhaler is only going to help with the outside of the airways, the bronchoconstriction. This is not a disease of bronchoconstriction, whereas this blue inhaler is absolutely key for those emergency situations, life-saving. So we need to think of this as the life-saving emergency treatment. So next slide, please. So because of this as well, I think this is why Gina had come up with that big guidance that came out. It's a strategy actually that came out last year. It was groundbreaking, and to prevent people from just using blue inhalers alone, what they're suggesting is every time a person is thinking of just getting the relief, they're actually getting background anti-inflammatory every time. And this is why they considered things like ICS formoterol as their sort of solution, and because, as I say, we've got a lot of patients out there that have got the blue one close to them. It's almost like an over-reliance, an addiction to that blue inhaler. And actually, if you're using that alone, it can be pro-inflammatory. And studies showed anyone using more than 3 blue canisters a year is at risk of being hospitalized. There's quite a lot of research around that. And we've got to remember, anyone who's saying that I'm using it for exercise, that's BTS sign clearly states that that's generally a sign of poor asthma control if they're having to use it for exercise all the time. So it's not one of those things that we should be sort of encouraging. And really as well, I think, yeah, if we go to the next slide, please. So let's look at this case study, which if we go to the next slide. Just for a couple of moments, because I know time is running on this, I wanted to remind you of the 3 basic elements of basic care. Good annual asthma review, absolutely. Good inhaler technique, absolutely. And having a personalized asthma action plan, absolutely. This survey that I looked at was quite shocking when I saw around 88% of people between the ages of 19 and 24 are living with poor asthma control. They think that's normal, day to day, living with symptoms, nighttime symptoms, daytime symptoms, thinking this is absolutely normal. And this shouldn't be the case. Okay, next slide, please. So in the community pharmacies, I've been trying to get them involved in Northwest London, for example, around and North Central London, of course, is around helping identify patients who haven't, for example, got an asthma action plan. And that's quite common because the National Review of Asthma Deaths found around 77% of patients who died didn't have one. This is not good. So you're 4 times less likely to be hospitalized if you have one. Next slide, please. So this is just highlighting how if we can get the green section of the asthma plan filled out by the patient in the pharmacy, and then the rest of it could be signposted back to the practice, I think this is really good partnership working. I'm surrounded by things like lung tubes, which you can really good resources that I've been sharing with practices across as well, just to help people understand what good asthma looks like and what bad asthma looks like. Okay, next slide, please. Yeah, next slide, please. So this is a case study of a lady called Joanna. It's a fictional character, but 22 years of age. She's been recently diagnosed with asthma, but she was appearing in the pharmacy quite a lot, buying cough bottles, getting nighttime use. She did have spirometry, obviously not now, but at that time. It demonstrated reversibility, and she basically was given a blue inhaler with a spacer, and was also given budesonide, which is an anti-inflammatory drug, and a dry powder inhaler. So there's obviously a lot of potential issues here. So the low dose of inhaled corticosteroid, absolutely BTS sign, and obviously the blue inhaler for emergency use was given. Because this lady found that her mother has asthma and the probability was very high, she thought actually the blue one is the one that gives me the benefit. So because of prescription charges, she just decided to take the blue one. So next slide, please. So what we need to ask ourselves is, how often do we follow up a patient when we prescribe the blue inhaler? Because, you know, really, I don't know any colleagues who do this, but if we said to a person, this blue inhaler should last you 6 months, if it's not lasting you 6 months, please come back in and see us. Imagine if we get this information from the very first time they get a blue inhaler. That would be quite good. So the person's expecting it's not normal to have to get one of these more than 6 months. Okay, so next slide, please. So what happened with Joanna is she was seen again in the community pharmacy 24 months later. She's losing, she's sort of in despair. She's thinking this is not working. She's bought lots of remedies to try and help her with her symptoms. She's thinking, why isn't this blue inhaler helping? It was the 6th blue inhaler she's got. And then finally, she reluctantly decides to get her other inhaler as well. But it wasn't followed up very well within practice and pharmacy. She unfortunately went on a course of oral steroids. She had an asthma attack. Life is not good for this person. So next slide, please. Yeah. So what the Primary Care Respiratory Society and the International Primary Care Respiratory Group have come up with is a very good behavioural change tool just to help people identify when SABA is, you know, the number of puffs. So say Joanna was on 6 SABAs, that's 23 puffs a week. The guidelines say anybody with good, well-controlled asthma shouldn't need to use their inhaler more than twice a week. So really 4 puffs or 6 puffs a week should be the maximal use. And then obviously if we go to the next slide, please. And then on the back of it, we can use motivational scaling questions. So this person's on their 6th SABA. So on a scale of 0 to 10, how important do you think it is for you to go and get a review and see your doctor? This could be used in the community pharmacy, or if you're in the practice, you could always say, so on a scale of 0 to 10, how important do you think it is for you to use your preventer inhaler regularly to try and reduce that inflammation? So next slide, please. So there's lots of great tools on the Primary Care Respiratory Society that will help you with this. And I tend to use it, look at the puffs per week. I would look at in the pharmacy, the patient medication records, ask the person, what have you been told about your blue inhaler? Really get the pharmacist trained up on this. And just highlight that basically, yeah, if the person's on their 1st or 2nd one and you've identified they're using 20 puffs a week, you could highlight that they're on course for getting 5 canisters a year and in the year if they carry on like that, and we can help them reduce that. So next slide, please. This is really just to highlight, imagine if we picked up on our records that after the 3rd blue inhaler had gone out, we could have prevented Joanna from having that initial asthma attack. We could have highlighted this person's on blue alone, not collecting their preventer inhaler, and obviously things would have been a lot better. So that's just a top line on this. Next slide, please. And there's lots of question and challenge cards. There'll also be a lot of steroid phobia going on with inhalers, and this is psychology might really help. If you're finding somebody's worried about strengths, you can use right breathe traffic light signals In the if you look at right breathe, you can see the traffic light signal. So if somebody is on a low dose of steroid, you can show that person, look, you're on a low dose of steroid. It's very low dose. You're not going to get side effects like you would if you're taking oral tablets. And in fact, our bodies naturally release steroids. And what we're trying to do is, because your lungs are reacting too strongly to those triggers from outside, whatever triggers you've got, what we can do with this low dose of inhaled corticosteroids is maintain that natural balance. And that's going direct to the site of action and not getting into your systemic circulation so much. So that's, I think, really important from an educational perspective around the importance of ICS, and really listen to the person's ideas, concerns and expectations. Next slide, please. And again, I think we've covered a lot of this, but let's finish off with the simples. Last slide. So we've done a bit around very brief advice, 30 seconds to save a life, smoking cessation and secondhand smoking, inhaler technique, importance of maximizing that. It's coaching, it's 50%. When we think of the drug, don't think of the molecules, think of the device and the molecules together. They work in harmony. Really need to treat it seriously. And then the monitoring, of course, as Jacqui was going through a lot of that, and checking people's pharmacotherapy adherence, thinking when we're looking at our records, looking at the ratio of their blue inhaler compared to their preventer inhaler, looking at the person holistically, and think of comorbidities as well. And this is why I loved group sessions as well. Education, absolutely key, and signposting to support. So that's I've not left long for questions, but please. Oh yes, and just to finish off, the Primary Care Respiratory Society has got some excellent resources around. If you're thinking, I'm in my asthma learning journey, and I learn a lot from Jacqui and other colleagues, and I know that I'll have my strengths and weaknesses. This is a good place to go when you're trying to find out what you can offer when it comes to standard respiratory care. If you go to the next slide, it gives you some ideas around advanced respiratory care and expert respiratory care, all the sort of things you can do on your learning journey to feel competent to do this, confident and competent. So no delegation without education. That's my last words on that. So thank you.
Thanks, Darush. That was excellent. You've not had many questions in the chat so far, although one's just popped up. But anyone, if you've got any more, either put your hand up or please do pop them in the chat. So how long would you allow for an asthma check?
Yeah, it's an interesting one, because when you talk about an annual asthma review, I'm hearing colleagues saying that I've only been given 10 minutes. And that's not enough time to go through all the things we've just been talking about. And it's really important it doesn't become a tick box exercise, and patients may never come back to an annual asthma review again if they feel like it is a tick box exercise. So I think, as I said earlier, it's a team effort. I'm fortunate that I can spend longer than that sort of time. I feel the people at high risk and medium risk, when you're looking at the UCL partners, we need to be thinking of those patients as the ones that need maybe follow up in more than an annual review, but they will need to be followed up, especially when you're changing strengths or up. Remember, they need to be followed up for step down later on as well, see how they're getting on. And for the ones who are low risk, or you're feeling that they're quite confident with things, you can absolutely do that in a much shorter session. And they may enjoy actually doing more remote consultations than face-to-face. And this is where we may be able to access those people that we were struggling to access before. So it varies. And I think it's all about us, really not only listening, but actively thinking about what's going on in that person's world.
Thanks. There's just one more question about any thoughts. You did cover it a bit earlier, but just that real challenge of trying to step people up from just the salbutamol, and with patients who maintain that all steroids, are dangerous or cause adverse reactions. Just any further tips from either of you of how you overcome that?
Yeah, so I've answered that earlier on, but I just wanted to see if Jacqui had her own thoughts just to share with the group.
I think we need to educate the registrars and the newly qualified doctors to actually not issue a salbutamol in the first place, and then that probably will iron itself out, maybe. But it is a difficult one, especially with those, especially with a little bit of inflammatory, allergy or exercise related symptoms only, and then they're all right for the rest of the year. I think it's about educating them into the processes from the beginning, bronchodilation plus anti-inflammatory. You can't do asthma without putting them together.
Okay.
And just to say, one final thing. Even in the National Review of Asthma Deaths, which I think Jacqui alluded to earlier on, even people who are defined as mild asthma, the ones we're seeing in primary care, there were deaths. And that was something that I think surprised a lot. So even this is why GINA, even with the milder steps where we're thinking just SABA alone, which shouldn't be the case, should always be ICS low dose, but they're always thinking if you're going to give reliever, you're always going to get background ICS, because to prevent even people with so-called mild asthma from getting morbidity and mortality.
Yeah, I think that's really good, clear message that you've put across today. So a last question then from Fanny, just asking about whether you've come across patients using their younger siblings' inhalers or parents' reasons that they cannot afford. And is there any plan in the future for patients to have free prescriptions for their inhalers?
Yeah, so Asthma UK has been lobbying for this. There was a big push around free prescriptions for everybody. In Wales and in Scotland, they can get free NHS prescriptions. So let's watch this space. Hopefully that is something that will change. But yeah, absolutely agree.
So listen, thank you, Darush and Jacqui. You've done a fantastic job on taking us through asthma and covering an awful lot of information within a really short time frame and giving us a lot of resources that will be really useful as well. So thank you both very much for that. That's been really, really helpful. A reminder to anyone, if you haven't put your email address in the chat, please do, so you can be sent the slides and a link to the video and the resources. And you're getting lots and lots of lovely thank you comments in the chat, and I think everyone will have taken something away from today, which is great. So thank you both very much. You don't really get a clap on on Teams, I'm afraid, but you're getting lots of dinging and lots of thank yous, so that's absolutely great.
Thank you.
Great, thank you.